I want to welcome all of you to our live conversation around overcoming therapeutic inertia. Uh, uh, my name is Bob Gabbay. I'm the Chief Scientific and Medical Officer of the American Diabetes Association, and I am really pleased to have two world experts on this subject. Both Dr. Brunton and Dr. Khunti have written extensively on this, have been involved in research. They're going to share some of that with us today. Maybe I will start by asking them to just give a little bit about yourselves, maybe starting with you, Dr. Brunton.
Thank you, Bob. So I'm a family physician. I work in rural South Carolina, as you can tell by my southern accent. No, I'm from the deep South, that's Australia, but I've been in the United States for a long time. I've been working in diabetes for a long time, since I was taller and had hair. So I've certainly had a lot of experience with this. I head up something called the Primary Care Metabolic Group. We're a group of about over 10,000 clinicians with an interest in diabetes and other metabolic diseases. I'm also editor-in-chief of the ADA's Primary Care Journal, Clinical Diabetes.
Great, thank you. Great to have you. And Dr. Khunti.
Hi, Bob. Hi, Stephen. Thank you very much for having me today. I'm Kamlesh Khunti. I'm a primary care practitioner in the UK, Leicester University, but my full-time job is in research in relation to cardiometabolic diseases.
Great. Well, great to have both of you here. And we're going to be sharing some important updates that'll be very helpful for both clinicians, but also people living with diabetes. So we have a diverse audience. There, in particular, we'll focus on a recent really important paper that was published that talks about strategies to overcome therapeutic inertia, and we'll define what is therapeutic inertia in a moment. So what are the strategies that we know work to improve glycemic control, to lower A1C? And what can we do about it? And we'll come up with some practical solutions that many of you can try, and really focus on the importance of a multidisciplinary team. This effort around overcoming therapeutic inertia is something that the ADA has been leading over the last 3 years with lots of stakeholders involved, and we're really appreciative of all of those individuals. We are so thankful for the incredible professional volunteers that have all been involved in this, including our two speakers that have been real leaders in this area. And so we're also want to hear some of your questions in the audience. So put your questions in the chat. We'll get to them hopefully at the end. We'll do as many as we can. And so without further ado, let's get started. Let's jump right in. So Dr. Khunti, what is therapeutic inertia? Why is this important? What is this all about?
Well, Dr. Gabbay, therapeutic inertia is basically failure to advance or even de-intensify therapy when it's appropriate to do so when patients' goals are not met. So in terms of advanced therapy is when we are not reaching the goal that we should be reaching. And to de-intensify, many patients we know are on therapies, they get old, they get frail, they get into nursing homes. What we're bad at is stopping therapy. So not de-intensifying therapy is also termed therapeutic inertia. And the reason for this is that all the guidelines are now saying that early glycemic control leads to better outcomes. But from the research evidence, we're not putting into practice, and we're waiting far too long to put people to the goal targets that we've assessed for these patients.
Great. So it is a real problem and underlies why glycemic control has really not changed much over the last decade.
Absolutely. So, it's about 10 years that we haven't changed the needle in terms of glycemic control. But there's lots of reasons. I mean, we could, there's a lecture in itself, but it's mainly patient practice system level problems that lead to therapeutic inertia. But there are simple things that we can do, and we'll talk about them from the new evidence that we've got. But if people want to learn more about this, there is a recording of our recent webinar, Overcoming Therapeutic Inertia, what you need to know, using the link in the chat that we'll put down.
It's interesting, that the focus is going beyond just the patient, but it's really, as you say, a whole systems approach. I think in the past we often kind of blamed the patient, that they weren't doing the therapy, they weren't doing it, doing what they should be doing. And I think it's recognizing that diabetes is a very complex disease, and we all have a part to play in this process. So yeah, this is a very exciting time to be managing diabetes because we have more therapies, but I think we're also understanding that it's a very complex issue and there are things that we can do about it.
Absolutely. And so you've both been really instrumental in the American Diabetes Association effort to overcome therapeutic inertia, this important initiative that we started some 3 years ago. Dr. Brunton, do you want to describe it a little bit, the work that's being done, and we'll also share more resources. And everybody check out the chat, both for your questions, but also for important links where you can learn more.
Thanks, Bob. I think that the ADA, once again, has taken a real leadership position in this. I mean, the goal of the ADA is obviously improve diabetes care and recognizing that there are things that prevent us getting to goal, and therapeutic inertia obviously is really an umbrella that encompasses these things. So there are really 3 different priorities with the ADA's whole program. One is research, and the ADA is certainly funding research on the topic of the best practices to overcome therapeutic inertia. The second is looking at collaboration and collaborative barrier busting. So there's an alliance with various partners, the American Association of Nurse Practitioners, the American College of Osteopathic Family Physicians, the American Pharmacists Association, American Society of Health System Pharmacists, and the American Medical Group Association. They're folks that have an interest in this, and other groups are now joining this process to try and see what we can do as larger sort of clinician entities. The last, and I think for me personally is the one that I'm most interested in, is the education awareness. And it's a key aspect to ensure that all clinicians involved in the management of diabetes are really part of a team, that they're aware of therapeutic inertia and have the tools to bust these barriers in their practice. So I want to highlight, there's a great new program that's just launched last month. So it's very up to date. It's the Overcoming Therapeutic Inertia CE certificate program. So you can get recognized for the work you do. This is a brand new curriculum. It's devoted to helping clinicians be able to identify therapeutic inertia and apply strategy to overcome it in their practice. So you can learn more about the specific program and sign up today. I feel like I'm selling knives or something. Sign up today using the link in the chat.
The good news is you're selling better health for people with diabetes, and so that's a very laudable. And so this continuing education program literally sort of walks clinicians through what they need to do and how to do it.
Exactly.
Great. And those many organizations that you described that are part of this initiative really sort of speaks to what will continue to be a theme as we talk more of the role of the team. It's not just the one doc that is supposed to do all this, but really the team. So as that sort of foreshadows a little bit, so Dr. Khunti, you led a number of investigators to really look at the science. So what do we know about overcoming therapeutic inertia? People have been at this for a number of years. What works, what doesn't? And so do you want to tell us a little bit about that research? And we can put the link for the paper itself that people can read. But tell us a little bit. Yeah, what was the paper about, in case people don't have time to sit down and read the whole thing?
Yeah, so Bob, there's been so many studies on therapeutic inertia, but all of them is what the problem is, how bad the problem is. And this was the first attempt to systematically look at interventions that have been done to overcome therapeutic inertia. And we're quite surprised there are a lot of interventions there for overcoming therapeutic inertia in people with type 2 diabetes. Overall, we found about 36 studies, over 20,000 patients in these studies. And the interventions we looked at were care management programs and patient education programs. These were care management interventions, virtual coaching, telemonitoring, all the kind of things that we do. We looked at physician-based interventions. We also looked at nurse or certified diabetes educator-based interventions and pharmacy-based interventions. And We put them into a systematic review, as I mentioned, and looked at what the best effect sizes were for those various interventions that we'd identified in the 36 studies.
So you read through all of these studies, narrowed it down to the 36 best studies, and then exhaustively went through that. So tell us, what did you find?
Yeah, well, it was interesting that the largest reduction was with nurse-led or certified educator-led interventions. We found in the meta-analysis about a 1.62% reduction in HbA1c. These were all studies.
1.6. Wow.
1.62%, yeah.
That's a big drop in A1C.
Absolutely. These were all studies that were done at 12 months results. The next highest reduction was with pharmacist-based intervention, which I was interested in because we're bringing a lot of pharmacists in primary care at the moment. We haven't got enough doctors to look after patients in primary care, so we're employing lots of pharmacists who are looking after people with hypertension and diabetes. And we've this systematic review found a 0.9% reduction with pharmacists. And the least reduction, surprise, surprise, was with physician-based interventions.
Wait a minute, that's not fair.
Here we're a group of physicians, and we're really saying that it's the other team members that are going to get this done.
A 4.4% reduction with physician-based, and then it's obvious to us we haven't got time, to spend with the patients, while the pharmacists, the educators, the nurses have a lot more time. We're often, when we see patients, we see them with lots of conditions in primary care, particularly. They don't just come with diabetes, but when they go and see the pharmacist or the nurse, it's a diabetes-specific consultations that they're going to have. Yeah, so very, very interesting results.
But I think also in that situation, Kamlesh, that not only is it time dedicated to that, but it really speaks to the fact that it really does take a village, and people that have been trained in diabetes education certainly have some of the skills and tools that can access that. What I'm finding in our environment is that the diabetes educators are really not used enough, and we can in a sense overcome some of the time constraints we have in primary care by utilizing other members of the team.
And I think we've learned a lot through the pandemic, because before we used to do everything face to face. And now, our diabetes educators, our nurses, they're doing remote consultations. So I think there are a few positives that have come out, not many, from the pandemic, but I think we're going to see a lot more remote consultations, which patients have really embraced them.
Yeah, I think you're absolutely right. Involving other members of the team, and one of the misconceptions I think some people have is that diabetes educators are just educating, but they do more than that, right? Like, I've had patients say, I already know about diabetes. I know what I need to do. I'm just not ready to do it or whatever. But they help to break barriers.
Well, education is more than just giving information. It's really sort of understanding, as you said, what are the barriers, and particularly if we're talking about overcoming therapeutic inertia, understanding the particular challenges that each patient faces, can work with them to accomplish those very astonishing results that Kamlesh showed us.
So, if I'm let's take two scenarios. One, I'm a primary care provider, or physician, nurse practitioner, physician associate out there. What can I do? Like, what should I think about doing? What might be the next steps?
Well, I tell you, one of the things that I find very interesting is that, well, you say patients say, "Oh, I know about it," but actually a lot of people think they know about diabetes, but don't. One of the first questions I ask is, what do you understand about diabetes? And that can really help me target the intervention to overcoming some misinformation they may have, but also, in a sense, going to the issue of what are the specific barriers that they're facing. And so we can all do that. I think, everyone involved in healthcare, certainly the additional resources that Kamlesh studied, but even with our own practice, we can really maximize the utility of the limited time we have by focusing our questioning and really doing some problem solving with the patient.
In terms of the way I look at it, as I mentioned, there are physician-level barriers, healthcare professional, patient-level barriers, and system-level barriers. System levels are kind of things that access is a problem. You can't prescribe certain medications. That's a difficult one to sort out. But that's only about 20%. The rest are really with the physician and the patient. And the patient level and the physician level sometimes have to work together. So telling the patient that this is the target I'm aiming for, that giving the patient that one specific target that we're working towards. And noting that in the notes as well. So if the patient is being seen by someone else, they know what the target's been discussed. And there's been good studies we've done, others have done. If the patient knows what their target is, they're more likely to get to it. Secondly, the reason inertia occurs is because we collude with patients. They come at 3 months, they come at 6 months, and say, "I'll try harder." And we say, "Fine." And suddenly, "I'll try harder" goes to 2 years to 7 years. We don't do that for hypertension. In hypertension, if patient's not at target, we up the medications very, very quickly. And I think this is what we need to do. And this is also in the ADA guidelines. This is on the ESD ADA position statement or consensus report. There's a circle at the top, the blue circle, and that says to avoid inertia, assess and treat every 3 to 6 months. And I think that's something that we should be doing. And then finally, I think using the people that we've mentioned in the systematic review who can lead to better outcomes.
An important point, I think, with Kamlesh, of why it's important to do that, probably more so than in these other sort of conditions, is the legacy effect. That by sort of managing these patients very effectively as soon as we see them, and not treating to failure, but treating to success.
Absolutely.
If we do that earlier the better, we're less likely to see some of these consequences that can occur for long-standing diabetes.
And as you know, Stephen and Bob, there's lots of evidence. Inertia leads to worse outcomes, microvascular outcomes, worse macrovascular outcomes, and worse mortality outcomes as well.
Yep, blindness, kidney failure, heart disease, all of that. And one thing I want to highlight, that idea of setting a time limit. So people might, a patient might say, "I'm going to work on this," and negotiating. All right, do that for the next month or two. But let's agree now that if you don't get there, then we're gonna advance therapy, and sort of negotiating that up front, because you're right. I think the scenario you described, every clinician that's listening, I'm sure has had that. Well, next time, I really gotta,
And the other one, the simple one we've done and looked at in the UK, and I know Stephen's done a lot of this type of work, is doing an audit. Say, look at your last 10 patients that you've seen. What were their targets? Did you note them, and did you get them? If they weren't at target, did you do something about it? Because physicians think, I don't have a problem. Unless you audit your work, you won't know if there's a problem or not.
Yep. So I'm going to remind people to put questions in the chat. This is moving quickly and very dynamic conversation. So maybe we've teased people's interest and they want to learn more. So there is the program that they can be involved in, the continuing education, and get certified in a sense, a certificate around this. What other resources are there that people can avail themselves of?
Well, I think what you said, the fact that there's a comprehensive program that really addresses many of these things, is going to be very useful, because it systematically talks about how, based upon evidence, what actually will work. So I think that's probably the best resource. Kamlesh, you've worked in this area forever. What resources do you use?
If you just do a Google search, there's lots that you'll find. Google Scholar has lots of things in there, but the OTI education program is a great resource, and gives you practical tips and resources to overcome barriers. And you can access many of these resources, including the best practice frameworks, patient, clinician resources, at our website. We'll put on therapeutikinertia.diabetes.org.
Great. That is a great website. And I'm getting in some questions from people. Here is, are you seeing underutilization of certain therapies there was the question around metformin, but also the use of cardioprotective drugs like SGLT2 and GLP-1 medications and the value of them in this therapeutic inertia environment.
Let me have a crack at that, because I think, we have a very restrictive formulary, so I think I'm allowed to use insulin and leeches, so that kind of prevents us getting to really taking advantage of the cardiovascular outcome trials. But I think what I've done, particularly patients who are at risk, I think you need to think, what would you treat your family member with? And then really, in a sense, utilizing that best evidence. And I've argued with basically insurance companies saying, look, this patient, especially if they've had a cardiovascular event, saying, I need to get your name if you're rejecting this, because this patient needs this. We see evidence that's going to prevent the development of this major adverse cardiovascular events, and this patient needs it. Now, it may be that we have to do that extra step, but in the long run, that's going to improve outcomes for patients.
And we've looked at this at a global Discover study, US, UK data, and all of them show, despite us having the EMPA-REG trial that came out, 5 years worth of evidence we've got now, it's still not translating into clinical practice. So people with established cardiovascular disease, they're not getting these therapies. And Steve mentioned access to therapies. Well, in the UK, we don't have that problem. We have universal coverage, free coverage, and as a primary care practitioner, I can prescribe everything. But despite that, we still see inertia in the UK as well.
I think the 88 standards of care have helped us a lot, because I think now, by able to stratify patients and talk about the newer therapies independent of prior metformin use or goals, that we should be looking at these patients as stratifying them based on heart failure risk, atherosclerotic vascular disease, or renal risk, then that really does give, I think, powerful support for doing the most appropriate therapies.
Yeah, that's a good point, Stephen. That is something that's new in this past year's standard American Diabetes Association standards of care, is really thinking about the comorbidities and thinking about therapy based on that, and starting that up front, whether people are on metformin or not. So that is new. So I have to ask the sort of mandatory question. So the pandemic, how has this affected therapeutic inertia, and what do people need to keep in mind there?
Well, I tell you, in South Carolina, we can't convince people to get vaccinated because COVID doesn't exist, so it's not an issue for. No, the thing is that it has changed things a lot, because a lot of patients may be more reluctant to come and see us, but in some ways it's an advantage, because it's patients who have to travel a long way, we can access them now. If they have access to a computer, we can access them in new ways that we couldn't before, and you can look at CGM data. You can look at a lot of things to actually make it more personal. It's like I wrote an editorial. I called it this is the 21st century or house call, because we can get them to open their fridge and show us what's in there, and then criticize. No, we can at least see what people are living like. So I think there's some advantage, obviously disadvantage. I know, Kamlesh, you've had a lot of experience with this as well.
Yeah. So there's lots of data that after a natural disaster, risk factor control will get worse in people with diabetes. So they saw this after Hurricane Katrina, which wasn't a long pause. But even after Hurricane Katrina, there's good publications showing risk factor control got worse in the short term, and then that leads to worse outcomes in the medium term. And we're already seeing there's lots of publications that have come out during the COVID period that risk factor control, HbA1c is worse, blood pressures are worse. People have more psychological problems, depression's gone up. That leads to poor adherence, and weight has gone up as well in people with diabetes. The only people who we've seen good quality control is people with type 1 diabetes for some reason. And most of the data that's come out so far shows people with type 1 diabetes have had good control, or it hasn't got worse. But for type 2, certainly a lot of data coming out that it's got worse. Secondly, we haven't been diagnosing as many people with type 2 diabetes as well. And there's some data now coming out on that as well, that there's been a reduction in the number of people with diabetes. Now, these people are going to have high glycemic control undetected. And we know just a 12-month delay in intensification leads to worse outcomes, microvascular, macrovascular, and mortality outcomes. So I think what we need to do now, we need to start thinking about our recovery phase and start prioritizing patients, which are the highest risk patients, and they're quite obvious. You know, the ones with complex diseases, renal diseases, cardiovascular diseases, a number of uncontrolled risk factors. And we need to start bringing them in and getting them to control as soon as we can, really.
Yeah, it's really, to both of your points, it's really about doing outreach to individuals that have not been seeing their provider. And now we understand that telemedicine can do so much, not necessarily a replacement completely for in-person visits, but certainly we, you know, with data transfer of blood glucose data, we can do a lot. You know, we're running out of time, and I apologize to the questions that I didn't get a chance to answer. We'll try to get our group together again in the future. We have a lot of programs around overcoming therapeutic inertia. The easiest way to learn more about this, and we'll put this in the this link in the chat along with the other links that you've seen in there. It's therapeutikinertia.diabetes.org. So therapeutic inertia, one word, .diabetes.org. You'll see lots of information there on the website, quick videos that you can watch just to get a quick primer. Really recommend the certificate program. You'll get continuing education credits. As part of that, you'll see information on that. And I very much want to thank our two incredible speakers today that literally are world experts, wrote the systematic review that the evidence that we're sharing is based on. And so thank you both, Dr. Khunti, and you know, so appreciative for both of you doing the great work that you're doing, for volunteering with us to lead this effort. Has really been sensational. I also want to thank the many other volunteers and professionals. And so both Dr. Khunti and Dr. Brunton, thank you so much for joining us. Audience, thank you.
My
And please spread the word, because this information and this session will be recorded and you'll have access to it. So tell your colleagues about it as well. With that, we'll sign off, and thanks everyone for listening.
Thank you.
Thank you.